for those of you who are on Twitter, I just want to address the elephant in the room, which is that applications to heart failure fellowships have been declining over the past few years. And I think to many of those of us in the field, this is very surprising because I personally find this to be such a deeply rewarding and really fun subspecialty. So hopefully tonight we can convince you why heart failure is the best. So I'll just introduce myself. I'm Sarah Chuzi. I am entering my third year on faculty at Northwestern in Chicago. And I spend about 40% of my time at our VA, where I've started our heart failure program. I wear a few hats. I'm also an associate program director of our medicine residency. And then my clinical and research interest really is in the intersection of palliative care and heart failure. So I have started a clinical program here that's related to that. So I'm just going to let our other panelists introduce themselves. I'll just go across my list. So Chase Stroud.
Yeah, hi. Thank you so much for help arranging this. And I echo what you say. I think it's such a great field. So I'm Chase Stroud. I finished my heart failure training in 2022. I served as the director of pulmonary hypertension at Oklahoma Heart Institute in Tulsa since August 2022. Time flies. Just to let you know, it's essentially a private practice, small LVAD center. We do a bit of everything, amyloid, HCM, CardioMEMS, industry-sponsored clinical trials, and of course, pulmonary hypertension. A passion of mine is invasive cardiopulmonary exercise testing, and one of the things is I established the program here at OHI in November 2022, and that's been very successful in the community space. So happy to talk about that and sort of my, I guess, call it career that makes me feel very old, but excited to be here.
Awesome. Thanks, Chase. Khadijah Breathett.
Hi, everyone. My name's Khadijah Breathett. I'm a heart failure transplant cardiologist, physician scientist, tenured associate professor of medicine. I'm the director of the Cardiovascular Equity Research Program, all at Indiana University. I finished heart failure fellowship in 2015. And I did a postdoc fellowship at another location, as well as a AHA postdoctoral fellowship and T32 Masters of Clinical Science for 2 years before starting my first faculty position, of which I was there for maybe about 4.5 years before I was recruited to lead the Cardiovascular Equity Research Program at Indiana University, now as tenured faculty. My work focuses on how to improve the delivery of clinical care so that our systems can be more equitable. And it's the guiding force behind why I chose this specialty and chose this career. And look forward to chatting with you a little bit more about this later.
Thanks. Ran Lee.
Thanks, Sarah. Good evening, everyone. It's a pleasure to be a part of this panel. I'm Ran Lee. I'm a heart failure cardiologist and a critical care cardiologist at Cleveland Clinic, now entering my 5th year as faculty. So in my roles, I get to help co-direct our heart failure ICU, kind of associate direct our CICU, and have a role in both. And I get to be associate PD for our general cardiovascular medicine fellowship as well. So I'll touch upon just kind of where that intersection of critical care cardiology and heart failure transplant cardiology really intersect in this next hour.
Cool. Marty Tam.
Hi, everyone. Thanks for having me. Marty Tam. I'm a heart failure cardiologist and an echocardiographer at the University of Michigan. I was actually co-fellows with the one and only Dr. Ran Lee, but I stayed on board and been there 5 years now. A lot of my work focuses on medical education and developing a career in that. I have a master's in health professions education as well that I completed after fellowship. I have a couple roles within the University of Michigan. I co-direct the medical school cardiovascular sequence. I also am the program director for the Heart Failure Fellowship and the associate program director for the General Cardiology Fellowship. And I do a lot of work on the sort of professional society level with the American College of Cardiology, and other organizations, including the ACGME, thinking about milestones and competency development.
Awesome. Haider, Warraich.
Hi, everyone. It's good to be here. Thank you, Sarah and Shashank and others for the invitation. My name is Haider. I'm a heart failure cardiologist based in Boston. I've completed fellowship from Duke and just continuing the theme. My co-fellow was Dr. Fudim, who's going to be introducing himself soon. I came back to Boston and was primarily at the VA. I had a joint position between the VA and at the Brigham. At the VA, I eventually led the heart failure program, and then last year started a full-time position at FDA, which is where I currently am. My other interests include research, writing. So yep, excited to be here and looking forward to everyone's questions. Thank you.
How many books have you written?
Too many, I think, at this point.
Awesome. And then Dr. Fudim, last.
Hey, my name is Marat. I trained with Haider, we were classmates, and I stayed at Duke. I'm an advanced heart failure doc. I spend the majority of my time in the cath lab. I actually, while advanced heart failure trained, do majority of my care actually in the HFpEF space, device space, and right now site-based research at Duke across the system and do remote monitoring. Those are sort of my clinical academic hats.
So already, I mean, you guys can see like the diversity of probably what we do in our day-to-day lives on this panel. Everyone does something very different. If people are near, the react button, I mean, I'd love to see how many of you are residents, if there's any way to sort of put that in the chat, or, raise your hand. Maybe not. If you don't want to, it's totally fine. Anyone fellows? All right, we're gonna get you guys to warm up. Okay, great. Fellows, cool, love it. Okay, a lot of fellows. Fellows, hi Shazli. Cool. Okay, a lot of fellows, awesome. Thank you for being here. Resident, hi. Great. So this is meant to be interactive. I mean, I have a few planned questions for the group, but I do want to leave at least 10 to 20 minutes at the end for questions for our panelists. So think of questions, drop them in the chat at any time, and we're really just going to ask each of these panelists sort of what they do, how it's unique, and how doing heart failure fellowship helped them get there. So I would love to start with Dr. Breathett, who is our representative physician scientist and does some really unique research. So would love to hear a little bit more about your research. I feel like you have really been a pioneer in this space, and it's something that a lot of younger trainees are interested in, sort of allocation of transplants and equity. Dasley, thank you for showing your face. Love it. And just wanted to know sort of when did you decide you wanted to pursue this physician scientist route, and what were some considerations when you were looking for your first job out of fellowship?
Sure. Thanks. I know that it appears there are a lot of people, some residents, some fellows. This is a decision I made really early, probably in medical school. I had a great mentor who asked me during, when you do those summer research programs, he said, "Do you want to get an abstract or you want to learn how to do research?" I was like, "I want it all." And he invested in me to allow for me to develop this whole pilot randomized control trial as a medical student, to help control blood pressure, made blood pressure control better. And I enjoyed it. It was great. Wasn't able to enroll enough patients to really get a lot of data from it, but going through that process and working with people from different communities, figuring out how we can critically think about making care better for someone else I was bit by the bug, but I didn't know how much I wanted to really spend doing that. I did my residency and my general cardiology and heart failure training at really busy clinical places that also had strong research availabilities. And so I had opportunities to lead additional projects at like residency at Duke, cardiology and heart failure at Ohio State that helped solidify that this is something that's important that I want to be a part of my career. And there's a program that I participated in that I don't think exists anymore from the American College of Cardiology that was called How to Become a Cardiovascular Investigator. And they bring all the bigwigs in. And it was like a day or 2 days. You go down to DC and learn what does it take? What are the different recipes for success? And American Heart Association, and I think they still do this, they had some early career days where they again showed you this is the recipe for success because we all know that cardiology is incredibly competitive as is. And that process of actually getting grants to do this creative work that you want to do is uber even more competitive. I knew that there was additional foundations and skill set that I wanted to do. And so I followed the recipe, although you don't have to, but I did the like a T32, a master's, got the NIH loan repayment award, got the K award, got the R01, and continued to getting additional other grants that move forward an agenda that I have to try to improve care for people, which is everything that we want to do. Um, a lot of what I see clinically that upsets me or seems like it doesn't make sense or isn't fair or isn't right guides me to wonder, well, why is that? And what can we do to make that different? How could we envision a future that's different? That provides better care for people. And that's really the guiding voice behind what I do and why I do what I do. Um, and if you have that interest as well, where you're seeing the way things happen and you want to see it done differently, or you have a vision of how it could be done differently, I'd say to get the foundation to learn the science, to learn how to critically think about the process and how to change systems, how to change behavior, and consider that it's a really it's an amazing life. It's an amazing career to have. It's incredibly difficult. There are incredible days where you get a lot of no's or things are not going your way. But when the wins do happen, they are incredible. And so I'd really hope that you might think about this field a little bit. And there's several on this panel today that have also chosen fields similar to this, such as being a physician scientist. And one other thing I think I'll add is I liked a lot of stuff when I did my cardiology fellowship. I was like, oh, I like this, I like this. And at one point, I thought about doing a dual fellowship, and I had a great program director that said, you're going to be in training forever, and how are you really going to be able to do all of those different fellowships and be a physician scientist and do this work that you really wanted to do? And first I was like, whatever, I can do it. But then as I thought on it about it really closely, and I had the opportunity to go to it's like a celebration of life that a patient had um, who was on the brink of needing a heart transplant and just their heart started to improve. And she invited her cardiologist, who's a heart failure transplant cardiologist, to the celebration of life with all of the family. And it was just so touching to see that relationship that he had with the entire family and how much love and actual respect there was over that time of seeing people at some of their darkest days and to improve and to do better. And I was like, I want that relationship. I want that. I was like heart failure transplant, I could do that. That can link with my research nicely. That's what I want to do. And that's how I made the final decision to decide not to be the super fellow and train in everything.
That's amazing. Thank you. I mean, I agree. This is a field where the highs are extremely high and there are some tough moments, but we sort of like get to be with patients on all ends of the spectrum. And it's a very rewarding field, as I said. So thanks for sharing. Chase, you have gone to private practice. Tell us, you've done it. You know, tell us, because you're not at a VAD transplant center, right? You don't practice VAD and transplant. So how was it helpful to you to do a heart failure fellowship? And, would you do it again? Like, what advice do you have for people? Why not just do a general cardiology fellowship and sort of take on the job that you have?
Oh, that's such an easy question. I think
In 4 minutes or less.
that's just so easy to answer. So yes, we do some LVAD, so but I think in general the majority of my practice centers around pulmonary hypertension and dyspnea, and I grew up in a small town, and sort of I wanted to provide excellent level of care in the community. I felt that was important, so I wanted to establish a really high level of clinical care in places that may not have that. And so that was sort of my drive to go out into the private practice area. I felt that sometimes in academics, it's harder to establish programs quickly. You may not have the buy-in from administration immediately. And I felt that honestly, research, writing grants and things were not my strong suit. And everyone has their different niches and strong suits. So I think it's important to find that. In regards to why, let's say if you didn't practice at a VAD or heart failure, a heart transplant center, why should you do advanced heart failure? Well, I think the epidemiological data speaks for itself, and just the fact of if you could just increase the rates of GDMT, prescription, but not only prescription, but also delivery and adherence is something that I never really hear, or I don't hear a lot about. A lot of us know what to do, and maybe our general cardiology colleagues know what to do, but they may not have the time allocation or the resource allocation to make sure that those patients get financial assistance, that they really understand the barriers to why those patients are not on GDMT, or maybe is this a HFpEF mimicker? Is this really amyloid? Is this really HCM? Are we doing, echo CPETs to evaluate for gradients during exercise and prescribing Camzyos? So there's just a whole world outside of just transplant and LVAD, and even knowing the appropriateness of when to refer and what could be potential barriers that you could solve and really make a difference in someone's life, or maybe pursue genetic testing and identify family members earlier. So I think in summary, I would certainly recommend pursuing a heart failure fellowship, even if your goal is just to provide excellent community care and you may not end up necessarily at a high volume LVAD or transplant center. I just want trainees to know that you're so needed in the community space. And our general cardiology colleagues are not delivering that level of care. And I mean, I don't want to be persecutory or anything, but I just think that that's what the data is suggesting. And maybe we're not doing a good enough job either, but I think it's important to recognize that it's not just about writing the prescription, but it's about really building a comprehensive heart failure clinic to let patients access those resources too. So yeah, I mean, I think I could talk about this forever, but I really appreciate that. But I hope that we get more people interested. It's just so needed.
I totally agree. And as we say, on the interview trail, when people are interviewing for cardiology fellowship, or heart failure fellowship, you should be able to tailor your fellowship to the type of heart failure that you want to practice. So if you come into heart failure fellowship knowing that you want to go to a more community setting where you're going to be the person doing HCM, amyloid, sarcoid, everything, then you should try, talk to your program director about how can you get a more well-rounded experience that's not focused as much. Everyone has to do VAD and transplant, but there's, so many different things that you can learn. And at least our fellowship, you should come to Northwestern, but it tends to be flexible. And if you want to spend a lot of time in PH or HCM clinic, amyloid clinic, like you are free to do that. And so it really just depends on sort of what you want to do. Marat, would love to hear from you. You have a unique sort of career breakdown. Would love to hear about your collaborations with industry. What does this involve? And sort of what advice do you have for trainees who want to do what you do, and sort of maybe tell us, what your life is like.
Sorry, I'm off camera. Thanks for the question. Let me know if my phone is breaking off. But driving from work I was in a cath lab today, collaborating with industry and doing clinical trials. maybe I was allocated this topic, but topic to talking about industry collaboration. I mean, Khadijah made a very good point. This is going the academic route is not an easy feat. I also did my T32, my K, my R, and other funding along the way. There is certain pathways and pedigrees you can certainly go into. This funding is not getting easier. It's probably getting harder with time. We'll see how it's going to go with the new administration. It's probably not going to get much easier. So then the problem becomes, where are you going to find sources to do research? Maybe if you don't want to go this extensive, long route of NIH funding, and I think where industry funding comes in, you can be a well-rounded academic cardiologist and not have received a single dollar from NIH, whether that's working at Duke, the Cleveland Clinic, or a small center. The site-based research that drives innovation with device and drug industry is massive. For every NIH dollars, many more dollars spent by industry to support this type of work. So I think that I encourage you all to think broadly about sources of funding, and it can be funding to support your own work if it's something that also, of course, fits the industry, investigator-initiated studies, or something that is just where you quote unquote just decide to investigator, a sponsored research where you're just going to be one of many sites. That is, that's very well needed because many studies have hundreds and hundreds of sites contributing to these large clinical trials. And then, one thing to speak to the breadth, because I chose to go into the sort of this device innovation space, is because the space of heart failure is the one that is fastest growing, and Haider will know, with the amount of technology being approved and let go into this breakthrough device designation space, where you have so much cool early innovation. You can do the animal experiment, the N of 1, the N of 10 experiments. They come to the centers like yours, small and big, to make the projects happen. And it's very close collaboration with industry. And the nice thing is, because heart failure is one of the biggest unmet needs in growth, and actually not having enough physicians, the ratio of industry dollars, industry sponsors to smart individuals with good training is actually very good. So you get actually a lot of people reaching out to you if you are in that space embedded in, and you show yourself as a good partner. What a good partner means to industry is a whole different discussion, but I think you just want to be open to innovative ideas. Sometimes it's high risk, sometimes it's low risk, and you have to see if you can find appropriate patients for it. Anything specific to this, Sarah?
No, I mean, that was a great
It's a very broad topic.
No, that was great. And we'll get some follow-up questions.
Oh, I today I did, listen, Simon cardio. I did 2 CardioMEMS today. I did a gene transfer study. I did a diagnostic study with test blood volume. I exercised 3 people, and I did an LVAD RAM study. So I did 7 cases in the lab, then went to dinner with industry. We discussed crazy stuff. And I'm going to call with you all. I mean, what better lifestyle? The one thing that I think the best part about heart failure is that actually the people we are around and the opportunities to go FDA, industry, hardcore basic research, educational tracks. I think the breadth of opportunities is the key part that you can change on a dime your direction. That's really why I chose heart failure over, for example, just interventional. You do interventional. Hey, I have decently good hands. Haider will tell you what my nickname was in training, but like decently good hands. But you're stuck in the lab. You ain't going nowhere. You're going to see patients and be stuck in the lab. But heart failure, you can do it all. You can do it all.
You really can. I'll also say I'm never in my office at this time. I'm here because the lighting is better. But I've got kids and I have a very good work-life balance. So just, don't be afraid. Thanks, Marat. Okay, Haider, what do you do? How did you get there? And what advice do you have for people who want to be like even more outside the box with a career in heart failure?
Sure. So I work full time at the FDA, where I work as a senior advisor to the FDA commissioner, and my focus is on chronic disease. And I think that I think what we are seeing is that I think more than any other time before, I think the conversation about chronic disease really being centered as really the sort of primary public health crisis in this country is becoming very, very obvious. And I think that training in heart failure really prepares you well, not just to understand, I think really for this future where we're really going to be focused on cardiometabolic disease in general. I do think that a lot of these silos that we have around, who treats whom is going to break down. I think the other thing that heart failure prepares you quite well for is really population health. Because when you think about population health and when you think about the population that places the greatest burden on the health system, it is disproportionately heart failure. If you think about the fact that even though from a prevalence perspective, heart failure is not the most prevalent condition, but yet it is the leading cause of hospital admissions in this country. So by itself, I think you provide so much value to a health system, especially as more and more health systems move towards a value-based model. And this is something where I think being at the VA, and again, if someone's interested in VA jobs, I can talk more maybe sort of offline on that. But that's also a great place where you have lots of, and Sarah's nodding, she also is connected to the VA, but another place where you have tons of burden of disease, lots of innovative things that you can do really early in your career in a way that you can't do maybe in a large academic medical center. But I think to me, honestly, like the real reason I really wanted to do heart failure was that I really just wanted to be a great doc. I just wanted to feel like, if that I wanted to sort of learn cardiology and be a clinician who would have a level of knowledge that was more than most of my peers. And I felt like general cardiology training by itself just wouldn't give me that. And then what you choose to do with that is really up to you. You can be a full-time, you can be like Marat, you can be like Rand, you can be like, we have a lot of great sort of role models on this group. Or you could be really, leading the way in palliative care, which is what Sarah and I are really passionate about. So I think that there's tons of stuff you can do with heart failure. I do think that it gives you a lot of variety. Our field is exploding with regards to the need. Think about, amyloid, think about gene therapies, think about, adults with congenital heart disease, palliative care. There's so many dimensions even within heart failure that I think the need is only going to grow. So super exciting field. I think it keeps a lot of options open for you, as Murat's also mentioned. Lots of interest in the interventional space as well. Lots of innovation happening as well.
Thanks, Haider. Dr. Lee, critical care and heart failure is very hot right now. Tell us sort of how did you get here? And practically, how does one become a heart failure doc with a, focus in critical care? And how does this distinguish you from other heart failure clinicians in terms of, job search and marketing yourself?
Thanks for that, Sarah. So I was very much like a lot of individuals on this panel. I never want to leave the ICU. I never really wanted to stop taking care of the critically ill patient, but specifically the patient in heart failure related cardiogenic shock. I love devices, I love procedures, and it spoke to me. And so I wanted to do heart failure first and foremost because I still wanted that longitudinal relationship of being able to see those patients through their sickest and darkest times, and get them through kind of that very, challenging time in their lives, and bridge them to a destination, whether that's, LVAD, transplant, and then take care of them afterwards. And so I really wanted that role. I sought a separate critical care cardiology fellowship because I wanted to really hone those skills in intensive care, in ventilator management, in multi-organ failure. And I think on any given day, I have a really good split where I can wear a hat where I'm a heart failure transplant cardiologist who can intubate and take care of really complex ventilator heart-lung interactions on really complex mechanical circulatory support devices and manage flows and speeds and up titrate and down titrate. And in the same, day, a couple hours later, I can be a critical care cardiologist dealing with mixed shock, but who can also adjudicate someone for advanced heart failure therapies and still have the authority to do that. So it's pretty interchangeable in my day-to-day. My weeks are kind of built out when if I'm not on service, I have days where I help supervise procedures for the general fellows and the heart failure fellows. And then right heart cath lab time, clinic, reading some kind of critical care echo as well. So there's a lot of variety in the day by day, which I really love. In terms of kind of job search and training and, you know, pursuing both, that's the hard part, right? I think there is opportunity cost that comes with everything that we do in training, but I'm of the belief and opinion that to really do both well, you need to go through formal fellowships for both. Does that mean that you can't work in an ICU if you only are heart failure trained? Absolutely not. There's more and more data that's out there that says the heart failure physician is actually the best person to manage in intensive care, even if you don't have separate critical care cardiology training. And there just isn't enough on the supply side to do pure cardiac critical care to staff all the ICUs or all the CICUs in the country. So I still think that there's a ton of opportunity and roles for heart failure physicians to round in ICUs, to be in charge of protocol design in ICUs, to manage MCS in ICUs. But I think if you are interested in both and have a dedicated ideal for a critical care career, dedicated training in critical care cardiology on top of heart failure is very complementary and beneficial with respect to that.
Thanks. Okay, Marty, you're unique. I don't know a lot of heart failure clinicians who have a focus in medical education. You have one both, you know, in your institution and then within these professional societies. So what is sort of a roadmap for building a career that's focused on med ed?
Yeah, and I will say that I have always really enjoyed the clinical aspect of what I do, the research and the education.
Go ahead. I'm still figuring out.
And I think for many of us, we end up having to pick and choose the things that we love the most. And for me, the clinical care and the medical education aspect were really important. I think having a good background through general cardiology and heart failure training actually really helped me in building my career, because I still do believe that heart failure cardiologists end up staying pretty up to date with all of cardiology, because we are the end stage, or the last place where many of these folks with cardiac disease end up. And we're also still a really good general internist as well, because we manage a lot of non-cardiac issues. And so that broad base, I think, has really helped me out in building my education career and being able to still teach people at all different levels. To your point specifically about, how do you build a roadmap for education? I think that for many of us, we do enjoy teaching. We love teaching. We love being with fellows or other learners out there. The question is, when do you take that step of, I like to teach, to then how do I lead and administrate some of that teaching at the end of the day? And I think for any of the fellows or junior learners out there, you really have to have that expressed interest pretty early on. I think for me, when I was both a general fellow and a heart failure fellow, I looked for almost every opportunity I could to do some professional development in education. So whether it was through my own local institution at Michigan, and I think many places have education type of tracks for people to learn from, or there's places like the Harvard Macy Foundation, there's places like through the American College of Cardiology, HFSA, other organizations as well, that help you either develop in leadership or develop in education. And so those opportunities, I think I went to more courses and did more programs than I care to admit to. But those things are really helpful to be able to say, like, this is the career path I want to build. And then I think that when opportunities come up to be part of education-focused committees and work groups, certainly take those up, because they all build upon each other and help you identify which areas of education you really want to be a part of. I'll say that I got involved, like I said, with many of these professional development courses early on, which led to different opportunities to be on education committees to these various organizations. It eventually led to working with the ACGME as well to develop milestones for both general cardiology and heart failure. Love me or hate me for being involved with that, but it's a big part of what we do in thinking about competencies. And I think I've just used that as a springboard to doing other things. And for me, once I became faculty, I thought, what else do I need to build up that skill set, which is why I pursued that Master's of Health Professions Education. Again, opens a whole new skill set and a different way of thinking about education.
Awesome. I'll just share 2 minutes about my path and my interest before we open it up for questions. So as I mentioned, I'm really interested in the intersection of palliative care and heart failure. And this was a path that a few years ago, I was discouraged by a few of my mentors to pursue this because it was sort of an unknown and sort of how are you going to meld those things? They don't really fit. You should do amyloid, you should do, prevention. And I think it's just you really just have to do like what makes, it's corny to say, but like what makes your heart flutter kind of. And talking to patients about their goals and values and sort of helping to take care of patients at the end of life has always just been almost like a meditative experience for me. So I, had to make myself legitimate. So, I took a certificate course at Harvard Med School on palliative care education and practice, and I got a master's in science and clinical investigation. And I'm right now just working on sort of clinical program building and a little bit of research. So I think like hopefully this just shows you that there's so many different things you can do in heart failure. And if it's really what you love, you can find a way to make your career path your own and unique and very satisfying. So it's 7:40. I would love to hear any questions from the group. Drop them in the chat. This is a safe space. We're not going to tell any program directors or anything, but would love to hear like any questions about, any of the paths that the panelists have taken, any follow-up. I'm comfortable with silence, so I'll just let it sit for a minute or so. Okay. Hi, Mike. Thank you for the question. All right. So current heart failure fellow at Northwestern. So for Dr. Breathett and others regarding development of foundational clinical research skills, how much of this occurred during your fellowship versus as early faculty? And maybe this is for research inclined people, but what was most important to you when looking for your first position? Because I know Mike's interested in research.
I think a lot of programs have, and I participated in all of them, like residency, fellowship, give you like a month, maybe two of dedicated research time. But that's real, and maybe a course or two, graduate level course I did. But that's not enough to be, and granted, I'm just telling you a recipe. There's a lot of different ways to get from A to B, and this is just a recipe to take the time to develop the skill sets. There are several programs that I can think of in the US that have really good, like a master's of science and clinical science. Some of them it's an MPH, some of them, I forget what the Duke one is. It's another master's something. But it's all basic idea where you're taking coursework that's hopefully directly applicable to whatever your area of study is, so that you're not just doing didactics, but you're actually applying it to your research area and developing a skill set. And I think that's a worthwhile thing to do just to help you be competitive and hopefully help you crystallize your ideas so that when it comes time, when you start your faculty position, you're able to hit the ground running in terms of being competitive for these early career award types of grants, which again, it's all about repetition, refinement, and really grit to get these types of awards. So definitely would recommend that. And you can usually I personally not trying to pay for any additional education or schooling beyond my medical school, have these programs pay for them. You don't have to, for the most part, pay for these programs. They have T32s, they're available. Postdoctoral fellowships, both, I don't know if he's still on, but Ruth and I both did like an AHA postdoctoral fellowship that paid for a year. It sometimes pays for more to get these skill sets that you need to be successful as a clinician investigator. Oh, and the other thing for faculty position too, because I've heard this before, people say, oh, they don't give you money, they don't give you time. That's a lie. The programs, the clinical programs that know you're serious about this type of position do offer time for you to get there. Some it's 3 years, some it's 2 years, some it's more. of protected time to help you be able to get that award. So don't be discouraged by that either, but it does vary from place to place.
Thanks. Another question from someone at Northwestern, very proud. Teju, who's a PGY3, she asks, are there any pathways for women's health and heart failure? So I'll let others speak to this if they know, but one thing I'll say in response to this is like, if there isn't a path, make a path. Find a mentor. So, how many years ago, Haider, I was like a general fellow at Northwestern, or maybe I was even a chief resident. And I knew that Haider was doing palliative care heart failure research. He was in Durham, and I was visiting a friend in Durham, and I just emailed him and said, is there any way you would want to get coffee? And he was like, come over for lunch. And now he's mentored me on 1,000 projects, and I'm obsessed with him. So, I think just like Teju, if there's people who are doing women's health, cardio obstetrics at other places, like write to them, do extra rotations in your cardiology fellowship, just find a way to distinguish yourself with mentors and training and just make yourself that person. Like write about it, tell everyone that you're interested in it, and then you will become it. But I don't know if anyone else has any advice on women's health specifically, or like how to create your own path track. Okay, that's your advice. Any other questions? Thank you for hosting. Hi, Donald. So for individuals interested in clinical and research efforts related to prevention, what are the pros and cons of pursuing advanced heart failure fellowship versus stopping after general training?
I can chip in on that. I do HFpEF as my main clinic. To some degree, it's early diagnostics. Some of that is prevention. I deal with a lot of comorbidities. I'm more of a medicine doctor and a heart failure doctor. I did not require a lot of my advanced heart failure training, but I can tell you that, this just a mixed bag of patients. There's PEF, there's REF, there's other diseases that sneak in. I do agree that certain degrees of prevention probably don't need advanced heart failure training, because I would say half of the advanced heart failure training will be wasted. Having said that, obesity management will be very central to what you learn, identifying comorbidity types, identifying heart failure phenotypes. These things you will not learn in general fellowship to the degree you will learn in the advanced heart failure fellowship. So, if prevention for you means identifying and treating liver disease, fatty liver disease, obesity, diabetes, then yeah, you don't need advanced heart failure training. But if that is going to be focusing a lot on comorbidity management, if it's thin heart failure, we had somebody who did that with us. They did advanced heart failure and attended the prevention clinic, and now they handled a lot of the obesity management, a lot of the comorbidity management for our populations.
Sort of speaking to the clinical role solely there regarding prevention and cardiometabolic aspects of our practice. If you're going to go out in a clinical role as a general cardiologist, you're probably not going to be allocated the same time and resources that we have and maybe take advantage of or take for granted in the advanced heart failure clinics. In regards to our patient visits are typically 30 minutes. In the community space, you're getting a 15-minute visit with your patient. We have heart failure triage nurses, PH triage nurses. We have someone that just works on prior authorizations, because there's a lot of this intention to treat that we see in the clinical space that doesn't end up happening because of so many different barriers. So I think setting yourself up as a heart failure cardiologist, I prescribe more GLP-1s than I ever thought I would. That's how you build kind of your practice for these advanced patients that may just be advanced because they're challenging to get to adhere to medications for multiple barriers. So I think you can sort of bake in that preventative aspect from the community care clinical standpoint. For the research side, then much better people on this panel.
Yeah, I will say for better or worse, doing subspecialty training as Chase, just to echo that, like you get more resources. Sometimes you get more, I don't know if respect is the right word, but there's definitely a difference between, general cardiologists and heart failure cardiologists.
Okay. I'm definitely taking the gray one.
All right. Karen, thanks for all your insights. I'm going to cardiology fellowship next July. My program does not have a dedicated LVAD transplant program. Would love to hear suggestions on how to gain more exposure geared towards heart failure in that setting. Great question.
This is
I can speak to that a little bit. So I'm at Cleveland Clinic. We do have visiting fellows come from all over the country doing away rotations because they don't have dedicated LVAD or transplant programs at their home institutions. So we've hosted people on away electives during general fellowship, typically PGY5, PGY6, as opposed to PGY4, just because it's a lot busier in that first year. But I would, encourage you to look for those types of rotations at centers that have them and are willing to take on external trainees for a month or so.
Yep.
Yeah, and as someone who has reviewed a lot of these applications, there are many folks who are in your similar position where their program doesn't have that heart failure, transplant, and bad exposure, and doing those away rotations, I think is definitely helpful in both solidifying your own comfort and knowledge and desire to take care of this patient population, but also gives confidence in your application to say, like, you've had this exposure and you're still this dedicated to it. So finding those opportunities, and there's a lot of them out there, is really helpful.
And you can also even think of it as a pre-on-the-job interview for, advanced fellowships, if that is a place that you would consider applying to for advanced heart failure fellowship later on.
All right, we have another question from Shazli. So she is starting Advanced Heart Failure Fellowship next year, and she says, when starting, how important is it to have a preset idea of what your niche will be? How difficult or easy is it to change paths / your niche once you're early faculty? I mean, I can take a stab at this. I think it just depends on what you want to do. And what kind of jobs you're looking for. So, I mean, Chase can probably speak to this too, but if you're looking for, well, I don't know, a lot of places, either academic or community, sometimes they're looking for a specific person. Like, do you have, do you either have specific knowledge in this area, or are you willing to build it up? Amyloid, remote monitoring, things like that. And so part of that is being a little bit flexible, when you're looking for jobs. I don't know if others have thoughts on that.
I think it's less important at the beginning of the heart failure fellowship year, but more so as you are interviewing for jobs and towards the tail end of your fellowship year, just to kind of get a sense of what you want to focus on within the field of heart failure. I'm thinking about one of our recent hires who did heart failure fellowship with us a couple of years ago, and then was hired, and she expressed interest in wanting to do more in the cardio-onc space, and that's something that we didn't have, and so that definitely helped, and we then could pour more resources into her, even kind of towards the tail end of her fellowship, getting her enrolled in courses and whatnot, so that she hit the ground running when she started her faculty career.
Yeah, I mean, it can be nice if at the beginning you have a sense of what you might want to do, because then you can use the heart failure year to sort of do more of that, wherever you can. So it's just sort of balancing like your own interests and desires and, your future employer, and how to kind of make yourself marketable, I think.
And I think it's totally okay to pivot, right? Like, you may come into heart failure fellowship thinking this is definitely what I want to do, and then you get more exposure to something else and you change your mind. And I think most programs are flexible enough to help you pivot. And like others have said, on the job search, there may be additional things that you might want to pick up skills in depending on what the market's like.
Other questions? Yeah, develop specific skills. The heart failure year is unique because you basically start your year and you're sort of looking for jobs like almost immediately. And so, you use that year to both apply and then, as Haider says, sort of develop specific skills after you get your offer, if that's useful. Hi, Mancy. Also pursuing Advanced Heart Failure Fellowship. Are there tracks and opportunities for a job to incorporate imaging, specifically MRI with heart failure? Anyone know about this? Again, make it a thing if it's not.
Yeah, I think I think in the clinical practice world, it's sort of hard to merge those sometimes, but I agree with Dr. Chuzi. I mean, you can sort of brand yourself however you like. I think echo goes a lot better usually with that. Sometimes the MRI is a little bit competitive for people that are sort of imaging focused to do MRI, CT as well as echo. And it may also be how your contract is carved out if you're really in the private space. I think our views are competitive, and if you have other people who want that imaging day or that time, it's sometimes hard, but it's totally negotiable, and I think you can brand yourself with however you like. And I mean, and I think there's a lot of focus between fellowship and your first job, but really we're all so young, and I hope to continue learning skills and hopefully rebrand myself several times. I hope it's not over, because this field is just exploding with new technologies. So whether you're academic or private, you probably should just envision yourself as a lifelong learner and someone that might pivot several times.
Okay, maybe we'll do one or two more questions. So current second year fellow, general fellow, wondering how much you're able to dictate how you shape your practice as opposed to your institution dictating what roles they need you to fill, given the shortage of heart failure specialists. Anyone have thoughts? Go
Sure.
ahead.
It's all
No, no, go.
negotiable. It's all negotiable. And so, yes, depending on what position you're applying for, they may have a specific role in mind that they want for you. Sometimes they say the best jobs are the ones that aren't advertised to you. So if you have in mind what you want to do, use your resources. Let your mentors know that. Let your sponsors know that. Because again, sometimes the best jobs actually aren't advertised so that that position can be created for you if it doesn't exist. Um, but yes, keep in mind what you care about. Make sure that you actually share that with those that are hiring you because they don't necessarily know otherwise what you want so that they can create the space that's good for you because they want you to be happy. They want you to stay. There's a big investment in hiring people and it's really important to retain them. So share what your desires are, share what you care about so that that particular ideal area that you want can be created. Now, starting off though, in your first position, you might not get everything you want. As you progress and you continue to have more success, you'll have more negotiating power as you move forward. But still be expressive about what you care about, what you like, so that your career can be developed accordingly.
Agree. And I would just say keep an open mind. We talked about this at the last early career talk we had, but I think a lot of us go into fellowship thinking we want to spend all our time, once we get a job, all our time in the ICU doing VAD and transplant. And, stage C heart failure is actually very exciting. And clinic, actually, I love, which I never thought that I would. I think we just don't get good exposure to clinic as trainees. It's like, I've got to go to clinic. Whereas when you have your own clinic, your own patient panel, I think that's actually like one of the best parts of my job. So I would say keep an open mind about, jobs that aren't totally concentrated at your academic institution. You know, so maybe one more question if anyone has. I'll give it like 20 seconds. Okay, well, thank you guys so much for coming. Thank you so much to our panelists. I am invigorated about heart failure, as I always am. But, you guys everyone on this session we're like a community. And so as I reached out to Haider and like forced him to be my mentor many years ago, please reach out to us. Like, we love talking about our jobs, and we love like supporting trainees and helping people navigate their careers. So our email inboxes are always open. So thank you. And thank you to Kelly for organizing, and thank you, Shashank, for leading that early career group.
Thanks, everyone. Happy holidays.